Okay, for complications of pregnancy, we'll first talk about diabetes, specifically gestational diabetes. It's when diabetes is first diagnosed in pregnancy with no history of type 1 or type 2 diabetes. The pancreas fails to produce enough insulin during the pregnancy. Without insulin, glucose does not enter the cells and they become energy depleted. This occurs in about 7% of all pregnancies. Because gestational diabetes does not cause typically any symptoms, most moms will have to be just routinely tested for gestational diabetes. This is usually done between 24 and 28 weeks of pregnancy. The mom may be surprised if the test shows a high blood sugar level because she may not have noticed any symptoms prior to. It's important to be tested routinely for gestational diabetes because high blood sugar can cause problems for both the mom and the baby. A pregnant woman sometimes that's been living with diabetes without knowing it prior to, and in this case, sometimes they're first diagnosed with type 2 diabetes in pregnancy. If they do have symptoms, it tends to be increased thirst, increased urination, and increased hunger. But back to the common common discomforts in pregnancy, a lot of times they may just think it's related to the pregnancy itself. Nursing care for gestational diabetes includes dietary education. We hope to control gestational diabetes with diet and exercise alone. If not, they'll be treated with regular insulin. We'll have to teach all gestational diabetic mothers to how to self-monitor their glucose levels. And if they are required to take insulin, how to administer that insulin. Also, frequent monitoring of their fetal status. So the second patient in pregnancy is the fetus, which we can't see. So with gestational diabetes, we want to make sure that we're monitoring that. I did mention regular insulin being the treatment of choice if it's not controlled by diet or exercise. Oral glyburide has been started to be prescribed for some gestational diabetic mothers, but as far as generalized routine treatment, if not diet and exercise, then we will consider regular insulin for class purposes as the treatment of gestational diabetes. Again, assessment, we said most have no symptoms. If so, then we mentioned that a lot of times they may be mistaken for just common discomforts of pregnancy. This is just a chart to show normal blood glucose levels. It's not that different than what you may have learned for your adult values. Again, the routine testing is done in between 24 and 28 weeks of pregnancy. Gestational diabetes will not appear until then due to the effect of pregnancy hormones. So we can't diagnose it any earlier than 24 to 28 weeks of pregnancy. It's diagnosed with an oral glucose challenge. There's a 1-hour test, which is usually done first. 50 grams of oral glucose is given, and then glucose levels are drawn serum, so blood values 1 hour later. Generally, if it's above 130 to 140 at that 1 hour, then they will be referred for a 3-hour glucose test. The 3-hour test, overnight fasting is required. The patient is to be told to avoid caffeine and smoking prior to the test. There's a fasting level obtained, and then 100 grams of glucose is given orally. So that's double the amount than the 1 hour. Then serum, so that's blood levels are obtained 1, 2, and 3 hours after, and that's where these values come from on the chart above. Nursing care includes diet education, we said, insulin administration, glucose monitoring. We've already discussed everything on this slide. This is actually a slide from your med-surg class as far as how to teach self-monitoring of blood glucose levels, to be reminded of that. We may refer for dietary consultation for diet, if, preferably we want these ladies diet controlled. Exercise helps maintain glycemic control. The difference in pregnancy for gestational diabetes control is we don't want to tell women to start a new exercise program. If they haven't ran marathons before, we don't want them running marathons or starting to run marathons in pregnancy. Fetal effects of gestational diabetes: macrosomia, so that is a large infant, difficult delivery, shoulder dystocia, polyhydramnios, which is an increased amount of amniotic fluid. So I usually tell students, think of it as diabetics tend to pee a lot. So think if mom has gestational diabetes, that goes to the baby, causing the baby to pee a lot, which causes increased amniotic fluid. And fetal hypoglycemia after birth. So the difficult delivery and the shoulder dystocia are both related to the large infant, which is macrosomia. The fetal hypoglycemia after birth, so the baby in utero is used to getting mom's extra sugar. So the infant or the fetus in utero starts to produce more insulin. Post-delivery, their body is still making that excess insulin, however, they're not getting mom's increased blood sugar levels, so they tend to bottom out and become hypoglycemic. Shoulder dystocia. Just to kind of give an example of what a shoulder dystocia is, this is a pelvis. I'm using a bear for a model because I can't find my baby. But with the shoulder dystocia, the head comes out. So you see the bear's head, we'll pretend there's actual vagina there and it's out. But the shoulders, we can pretend my hands are the bear's or the baby's shoulders, get stuck in mom's pelvic area. So the shoulders are unable to get through mom's pelvic bone. So in order to try to get them through, the nurse can apply suprapubic pressure. By doing so, if the shoulders are stuck, sometimes you can manipulate those shoulders back off of that pubic bone and they'll come out. So treatment could be nurse-wise suprapubic pressure for a shoulder dystocia from a large baby.